Hello, my name is Mikey. I will be briefly going over our project with data analytics class based off our patient treatment data analysis. So, our introduction, what we did was analyze patient data to formally improve care and efficiency. We used analytics to summarize the data and to explore patient satisfaction and performance outcomes. So our job for this project was to first do some research and focus on three significant variables. So we first focused on these three, which was albumin, HCT, and glucose. So in our research, we found that albumin was a protein produced by our liver and is basically an indicator of nutrition, liver function, and just our overall health. And for HCT, we found that this measures the percentage of red blood cells in our body and effectively reflects the body's ability to transport oxygen. And then finally, for glucose, we found that this measures our blood sugar levels. Both high and low values can sometimes indicate serious medical risks, including things like diabetes or hypoglycemia. So it's very important for us to break down this data and show some effective ways we can help hospitals. Right. So here we researched some normal and abnormal ranges for each of these measurements. You can see here that low albumin can often indicate chronic illness or liver or kidney disease, while the high levels may indicate dehydration. So as well, low HCT can suggest anemia or blood loss, and maybe even high levels could be linked to dehydration or smoking. For glucose, we found that the low values indicate things like hypoglycemia, while the elevated stuff could suggest diabetes about to start, or just being an increased risk of having things like type 2 diabetes. Two variables that are not included in the data set that we considered helpful for data analysis would have been blood pressure and heart rate. So these two vital signs are important predictors of patient outcomes because they showed real-time physical stability, and we believe that without these results, it can be hard to assess the severity of the illness at the time of administering the test results. So having these two would have been very impactful on our research.
Now let's talk about the length of stay. Firstly, its distribution is highly uneven. The mean is 5.1 for days, but it is heavily influenced by extreme outliers, so it does not really reflect the typical patient. The median is 3 days, showing that half of patients are discharged quickly. There is also a very high variability in hospitalization times, with a standard deviation of 9.5 days and a range going from 0 to 256 days. The extreme skewness of 14.07 and the very high kurtosis of 332.63 confirm that a few exceptionally long stays stretch the distribution. These outliers usually represent complex medical cases, such as intensive care, multidisciplinary treatments, or delayed discharge. Even if they are not usual, these cases place significant pressure on hospital resources, including bed availability and staffing. So planning should not rely only on the average length of stay, but should also account for extreme cases to ensure effective resource allocation within the hospital. The frequency distribution shows that most hospital stays are concentrated in the first few days. The highest frequencies occur early, with 386 patients that stayed 1 day, 289 that stayed 2 days, and 189 that stayed 3 days. Overall, most patients fall within the 1 to 5 day range, indicating efficient care pathways and good patient flow management. These early peaks suggest the hospital is effective at managing routine and straightforward cases, allowing for quick discharge. However, the more category includes 79 patients staying over 15 days. These long-stay patients have a disproportionate impact on staffing, bed occupancy, and resource allocation. In conclusion, the data highlights a dual reality. There is, on one hand, a fast turnover for most patients, and on the other hand, a resource-intensive, prolonged care for a small but significant subgroup. Now I'm going to talk about the gender distribution for the two comorbidities of hypertension and hypothyroidism. So overall, hypertension is more prevalent than hypothyroidism in both men and women, but the gender patterns differ between the two conditions. For hypertension, men have 351 cases compared to 326 cases in women. This indicates a relatively balanced distribution with a slight male predominance. For hypothyroidism, women show 62 cases while men have 42 cases. This reflects well-known clinical patterns, as hypothyroidism is more common in women. Hypertension is therefore by far the more common condition in this population. so the burden of chronic disease is shared across genders. However, the type of condition differs because men are slightly more affected by hypertension, while women are more affected by hypothyroidism. Now I'm going to talk about the patients with both hypertension and hypothyroidism. So this data shows how many patients have both comorbidities. Women account for 33 cases, which represent 57.89% of patients with both conditions, and men represent 24 cases, or 42.11 of the total. This indicates that the combined presence of hypertension and hypothyroidism is more common in women. This pattern is expected as hypothyroidism is generally more prevalent among women. Although the gender difference is not very large, it is consistent and relevant for clinical consideration. The implications are healthcare teams may consider gender sensitive screening and follow up strategies. Targeted monitoring could improve management of patients with multiple chronic conditions. In conclusion, this dataset highlights meaningful gender differences in comorbidity prevalence, supporting a more tailored and efficient healthcare planning.
Whenever we talk about data from a medicinal standpoint, it's always good to get some context on the patient cohort profile. In these two tables, we have descriptive analytics for both the cohort's age and weight. And as we can see, the average patient age is around 66 years old, with a standard deviation of about 12.5 years. The average patient weight is about 166 pounds, with a standard deviation of about 27 pounds. This tells us that we are dealing with an older population, and patients admitted are not typically severely underweight or overweight. This next data table and chart speaks more to the hospital's efficiency and how equipped they are dealing with this patient cohort. As we can see, the rate at which patients pass away within their first 30 days is about 3%, and the rate at which patients survive past their first 30 days is around 97%, making a ratio of about 1 death for every 30 patients that live. A look at weekly hospital admission and discharge trends tells us that the grand majority of patients are admitted during the weekdays, with a sharp drop-off during weekends. Conversely, patients are discharged most frequently on weekdays, especially Sundays. This pattern is most likely due to a coordinated effort to maximize bed availability ahead of the weekday influx, indicating another smooth operational system in terms of capacity management. For the three variables chosen earlier, below is compiled data within pie charts for categories of albumin levels, glucose levels, and HCT levels. When we explore the differences in HCT levels between genders of the patients admitted to this hospital, we see quite an interesting phenomenon. Usually, clinical studies will tell us that women tend to have higher rates of low HCT levels. However, within this cohort, it seems that men typically more commonly have lower HCT levels. This tells us that it's possible that the admitted male population may have a higher burden of conditions related to chronic blood loss or active bleeding. We also examine the average age for each glucose level within patients admitted. These closely clustered ages tells us that advanced age is a consistent feature across all groups and is not a factor that distinguishes patients based on glucose levels alone. Another important piece of correlating information is the admission source by glucose levels. The data tells us that 70% of patients admitted to the clinic and ER have high glucose, as well as 71% of OR admissions. This strongly indicates that hyperglycemia may be a compelling factor in medical and surgical emergencies.
Hello, I will now talk about predictive analytics and inferential statistics. Below is a table with 5 states and the results of their HCA-HPS score, or the Hospital Consumer Assessment of Healthcare Providers and Systems. There are also 7 variables that can be seen in the table, and I will talk about how we can use these variables and discover which are most significant to create a model to predict the certain state results. I have now ran a regression analysis that includes every single variable that was listed on the previous slide. Turning our attention to the column with the p-values in it, we can see that we actually only have 2 variables that are considered to be statistically significant. We will now need to run another regression analysis and get rid of any variable that is insignificant. However, we will do this one at a time, and we will start with the highest value, meaning it is the most insignificant. And for this, we will get rid of the discharge rate. Using Microsoft Excel, I have run multiple regression analyses, each time removing the most insignificant variable one at a time, but for the sake of this presentation, I have not included all of those. The regression analysis that is on the slide actually only includes significant variables, and those ones turned out to be the communication with nurses, communication with doctors, and then the cleanliness one as well. Now, if we turn our attention to the coefficients column, I've highlighted it in light blue. These are very important, and I will talk about that why in the next slide. We can now use the information from the model in order to predict certain state results. On this side, we can see that we have information from both Florida and Utah, including all of their variables with different scores. Now we will only be using the significant variables, which are the ones highlighted in blue. Using Florida, for example, we can see in the formula on the bottom right where we have multiplied each coefficient by this respective score and then have added them all together and the intercept value to that in order to get a final state result of 54.0569. As we can see, we did the same for Utah, keeping the same intercept value and coefficients values, and then added those all together and got a final score of 64.7086. Now I will talk about the challenges and lessons we encountered during this project. We learned that outliers and skewed distributions do require very careful handling. We also learned how important it is to organize the dataset in order to remove any inconsistencies and errors. For statistic modeling and challenges, we learned how important it is that the regression analysis model may need refinement in order to keep only the significant variables in order to be accurate, as well as misclassification of data or using wrong inputs will lead to misleading results. And for interpretation and context, we also learned how important it was to avoid false causation, how different definitions of normal may cause varied results amongst institutions, and then also that visuals are very beneficial in portraying data in an easy to read manner. We have now reached the conclusion of this project, so thank you so much for your attention.